just kind of how, what are the components of the LVAD. So this is a HeartMate 2 right here. This is a HeartMate 3 right here. The components that you have are going to be basically your controller right here. That's going to be connected to 2 battery pads, and that goes into a drive line. This drive line actually goes percutaneously into the motor here. For your LVAD HeartMate 2, this is going to be a continuous motor. So this thing is always working. They're going to have continuous axial flow using these magnets right here. This is blood from the left ventricle. This is blood that goes out to the aorta. One of the things that you get with that continuous flow that's a problem is it actually can build up stasis in the pump. You guys know what stasis can lead to? Blood in like one of these pumps? Clots, yeah, and that's a major thing you worry about. And that was the reason why they actually made the HeartMate 3. And what they found with the HeartMate 3 is actually called centrifugal force. Basically, blood goes into the top, spins, and blood goes out this way. One of the things that they changed on this is, though it's technically still called continuous flow, there's rapid variations in the speed. So it may go slow, it may go really fast. And what that actually does is decrease stasis in the pump. So the risk for a clot at about 2 years, basically a clot with inside the LVAD for a HeartMate 2 is 14%. High, right? HeartMate 3, the risk for a pump thrombosis is 1.4%. So a lot less, and that leads to decreased strokes in these patients and decreased need for you actually to take the pump out. For the HeartMate 2, about I think it's a 20% stroke risk at 2 years. The HeartMate 3 is 10%. And this new design was huge for this.
Yeah, I can see how.
Quickly go over this, and then we'll get into some questions. So just kind of looking over what are the things that you're looking at when you're basically patients on an LVAD, and how do you troubleshoot it? So the things you're going to look at is pump flow. Basically, what pump flow is, it's really going to be related, and I'll walk over here a little bit. So pressure of the blood going into the pump, the inflow cannula, minus the pressure of the blood on the outflow cannula. So things that this can vary is preload and afterload. If you have really low preload, then your pump flow is going to go down. Basically, there's not as much blood going from the LV into the inflow cannula, and there's not as much flow going through. The other thing that can do it as well is increased afterload. So if a patient's very hypertensive, you increase the pressure here, which decreases that pressure gradient as well. So flow really varies with preload and afterload, just like cardiac function, right? The other thing you're going to look at is like the speed of the pump and the speed. So this is what the actual, this is what the only thing that as a physician you can really change. And they'll basically set speeds in patients in certain situations to make sure they have good cardiac output, they're not congested, and they're not wet and they're not cold. What's up, Amanda?
I'm guessing this is something we would not do without the assistance of cardiology.
Yeah, it's a good one. So never, ever do anything without calling the fellow. There will always be a fellow here. They really, really want to know about these patients at all times. And honestly, they'll probably call the attending when you call them. Next one that we're going to look at is your power. Your power is pretty similar to flow. The only time that these can be really discordant is actually when you have a pump thrombosis. So pump thrombosis, the flow is basically going to stay the same, but you're going to have a power spike. And the reason why is it's taking more voltage to get blood through that motor, because that motor is obstructed, right? That's kind of the way I think about it, at least. The last one is going to be your pulsatility index. Flow is basically the cardiac output of the pump. Pulsatility index is the cardiac output of your residual heart function, right? For a HeartMate 2. So HeartMate 2 is completely continuous. Any pulse that you're going to get has to be from that LV still pumping. So it kind of varies with the same thing as the pump flow does, right? Preload, afterload, but you also have to think about the contractility of the left ventricle. All right, with that, we will go to our first question. Does anyone want to read this?
Is that a good or a bad thing? Like, if you have a higher pulsatility index, is that a good thing? Like, or is that a sign of a problem?
So your PI, I think you're going to be more, well, it depends. Depends on if the patient's hypotensive or not. Depends on the patient's blood pressure. Yeah, depends on the patient's blood pressure. So if they're hypotensive and you have a high PI, that means your systemic vascular resistance is probably going to be low, which is increasing your cardiac output.
Okay.
So that's one way to think about it. So it depends on the patient. And pulsatility index, from my understanding, I'm not an expert at these things, not as helpful in the HeartMate 3, because the HeartMate 3 does have some variation in pulse pressure, but it is helpful in the HeartMate 2. Usually it correlates well with flow. Anyone want to read this question?
Patient is a 60-year-old female with past medical history of idiopathic dilated cardiomyopathy with an EF of 15%, status post-destination LVAD 2 months ago, who presents with pre-syncope vomiting and bright red blood per rectum. Patient is initially treated with IV fluids in the ED, but patient is hypotensive 3 hours after. Her JVD is normal, cool extremities, hemoglobin is 9, Doppler blood pressure is 50, she's non-pulsatile, and her monitor shows a flow of 3, a power of 3, speed of 8,000, and pulsatility index of 3. You also say here the Hamabel VAD, chest X-ray, EKG are normal. How do you want to treat the patient?
Ask for more imaging. So the one thing I'll say is that, yeah, if you want to take a blood pressure in these patients, it's continuous flow. So you have to use a Doppler, and that Doppler is going to be similar to their map, right? All right. Anyone have any inklings? You guys want to talk about it for a little bit? Not febrile. Not febrile. Give her fluids. All right. So what I really want to, any other imaging that may help you? Yeah. So the echo is going to be really, really helpful in these patients. First, I'm just going to go through this, and really what I want to teach you guys is that hypotension in an LVAD is just hypotension with more information, right? Everything you do previously for hypotensive patients you're going to do, you just have some indicators that are going to help you. Does anyone remember going over this, we're going to go through hypotension real quick. Anyone remember what the formula for hypotension is? So blood pressure equals
Cardiac output times stroke volume.
cardiac output times
Heart rate.
So cardiac output is heart rate times stroke volume times SVR. No. Yeah, exactly. So what kind of things can lower your SVR? Yeah, Anna? I'm not going to write it all out because it's hard. What about patient's febrile? Sepsis, right? And then what about patient just had like is paraplegic or something? Yeah, neurogenic. So those are your 3 that you're going to think about. All those are going to basically decrease your SVR, causing vasodilation. And what's your cardiac output going to do in response usually? It's going to go up, right? So cardiac output, heart rate, which we're not going to go into, times your stroke volume, right? So what kind of things go into your stroke volume? What is it really dependent on? So contractility, right? So absolutely. So basically anything that messes with the LV in a normal patient is going to decrease your contractility. You can think of heart failure, but in the emergent setting, you definitely got to think about someone having an MI, right? And then you kind of go into, what was the other thing that it depends on? I think I said it already. Preload and afterload as well. I'm not going to get too much into that because in a patient with high afterload that has decreased cardiac output, that means they're usually going to be hypertensive. So preload. So it depends on things that are going to decrease your LV preload, right? And just thinking about things that can decrease your LV preload, really you have obstructive shock. So PE is a big one that can do it. You have tamponade, so you have increased intrapericardiac pressures that causing basically pressing on your RV collapse, decreased venous return, which is going to cause decreased preload to the left ventricle. And you're also going to think about a patient who may just have like a tension pneumothorax, right? So those are the 3 major things to think about. The last thing is going to be hypovolemic shock. So the things you always want to look at in these patients, and I kind of divide it into 3 quadrants. So anything that's going to decrease your SVR, they're going to be warm.
I wouldn't want to go have somebody sitting with back pain.
And anything that decreases your cardiac output, they're going to be cold. So any type of obstructive shock, they're going to be cold. And hypovolemic shock, they're going to be cold as well. The way that you can differentiate hypovolemic shock versus obstructive and cardiogenic. So anything that happens here is JVD, right? So hypovolemic is going to be low JVD. And then anything that's intracardiac in this area is going to be high JVD. So that's kind of the way I think about shock. That looks kind of messy, so I just hit you with that. Then how do we incorporate LVAD, right? How do we think about this in a person who has an LVAD? And basically you take this equation right here and you just change cardiac output with flow. Flow is basically equal to cardiac output from the LVAD. That's the way you want to think about it. So like I always have, when I think about shock, I always have this equation in my head, and then I just switch it over here, right? So this patient was what, low flow or high flow? Low flow, right? So this patient's low flow. So let's go down here. And what can low flow mean in a patient who has an LVAD in? The only thing that we really take out is LV contractility. LV doesn't matter anymore. All your blood is going into the LVAD here, and it's coming out here, and your LV is going to be completely offloaded. So what kind of things can you think of that's going to decrease blood flow to the LV? There's two really major types of shock left. Hypovolemic. And what's the other one?
Obstructive.
Yeah, so obstructive, right? Anything that decreases LV preload, you're going to think about that PE, you're going to think about tamponade, you're going to think about a patient having hypotension pneumo, and then you're also going to be thinking about hypovolemia. How can you discriminate hypovolemic shock versus obstructive shock with a physical exam? JVD, perfect. So that's kind of what I use. The other thing that you have to think about in these patients as well is they can get cardiogenic shock, not from their LV, from their RV. So they're still dependent on their RV to get blood, basically from their right ventricle to their left ventricle. So if anything affects the RV, like a arrhythmia, VTAC, or even an MI, and they get that, they still can go into cardiogenic shock as well, but the LV is completely offloaded. That's the way I kind of think about it. So let's kind of work through this, right? So first thing you show that this patient has a low flow. So what two shocks can they be in? I heard it, hypovolemic, obstructive. And what kind of helps you maybe on physical exam here that the patient is in one of those? The JVD, right? And this patient has a normal JVD. So that's super helpful. And then honestly, you probably could have figured this case out without all the information. Like I said, it's shock, but with more information. So yeah, if they have a low flow, it means that they're going to be in hypovolemic shock, cardiogenic shock from the RV, or obstructive shock. And if they're high flow, it's going to be something that either causes a pump thrombosis or something that is decreasing your systemic vascular resistance. All right. So IV fluid was right. Does anyone know the specific risk factor that patients with LVADs have that make them bleed? One of them, for sure, they're anticoagulated. Now, if you're going to be on LVAD, you have to be on warfarin and aspirin. So that's already a super big risk factor, is that they're on antiplatelets and anticoagulants. They can develop specific lesions in their GI tract due to their LVAD. AVMs, yeah. So they can get acquired von Willebrand disease. Basically what happens is your von Willebrand factors are getting sheared by the LVAD from that axial flow. And just like Hyde syndrome, with more shearing of those von Willebrand factors, they develop AVMs through their GI tract. So a lot of times when these patients bleed, it's secondary to AVMs. All right. So how can an echo help you in a patient with hypotension with an LVAD? I mean, honestly, it's super helpful, right? Because you can rule out obstructive shock. You can see if the patient's in tamponade. You can see if their RV is blown out. And you could be concerned if they have like a PE or something like that. I mean, you should get a chest x-ray in these patients. You can look at pleural sliding with an ultrasound as well, make sure they're not like tension pneumo. But another thing that's really big, has anyone ever heard of something called a suction event? I mean, this is all new for you, so I'm sure you haven't. So anything that lowers your flow, so we're looking at the 4-chamber view right here. Here's your LV. Here is basically your inflow cannula of your LVAD. anything that's going to, and here's your LA right here, anything that's going to decrease flow to your left ventricle can actually basically cause the left ventricle to underfill. And if the speed of your LVAD is too high, it's actually going to suck that LV cavity, making it smaller, which then obstructs your inflow cannula, leading to worsening hypotension. Scary, right?
Is like blocking the inflow cannula?
Exactly. It's a suck down event. So you're actually, the pressure inside the LV is so low that you're getting basically blood getting sucked out by your inflow cannula. And if the pressure is so low due to decreased preload in your LV, it can actually suck into the inflow cannula and worsen their hypotension. So that's a good question. So turning the LVAD off.
It's like a bad idea, obviously.
Yeah, no. What's a potential risk of turning an LVAD off? Clot, yeah, exactly. So you can actually only turn off an LVAD for 30 minutes before you are not allowed to turn it off again, or you can basically cause a huge systemic embolism.
We're not allowed to turn it off again or turn it back on?
You can't turn it back on. If it's been more than 30 minutes, you cannot turn it back on.
Okay.
If it turns off. So sometimes patients will come in and their LVAD shut off. I've seen this happen. And they'll be in like mild cardiogenic shock, like, oh, someone wants to turn the LVAD back on. You actually can't if it's been longer than 30 minutes. But I think you had the right idea. What's the only thing you can change with an LVAD? What's the only setting you can change? Speed. And if you're having a suck down event, do you think you want to increase the speed or decrease? Exactly. So temporarily what you do is you decrease the speed and then you fix whatever reason of why they're not getting enough blood to the left ventricle, right? If they're in an arrhythmia, you treat that accordingly. If they have an obstructive shock, you treat that accordingly. If they're hypovolemic, you give them IV fluid. So you guys were right here. So Fred got the IV fluid. The patient did have a quick look ultrasound here, which did not show a suction event, so you did not need to change the speed. All right.
Normally, like heart failure patients, I'm like, 250 cc's. Like, but if you have a bad, does it?
So I guess it depends, right? It would go accordingly of what shock you think they're in. If they're in hypovolemic shock and they have a working LVAD, I think you can probably do it pretty quickly, right? Because their LV is offloaded, so they're not really going to get pulmonary congestion because they're not going to get that pressure buildup because their LV is basically getting all that blood sucked right out of the inflow cannula. So I think if you think they're hypovolemic, this is a real patient, she was extremely hypovolemic, and we ended up giving her about 2 liters, and she got a lot better. She never got pulmonary congestion from it. She did well. And it was all those things that we thought about, right? She was bleeding. She also was throwing up, so she didn't eat for a couple of days. We treated her like a normal patient, but with a little more information, and she got a lot better. And she ended up having AVMs, which is why she was bleeding as well. All right, next question. Anybody want to read this one?
Patient is a 48-year-old male, past medical history of myocarditis, status post destination LVAD 6 months ago, who presents with shortness of breath and dizziness. Patient's vitals are heart rate of 190, Doppler blood pressure of 50. He is non-pulsatile. His monitor shows a flow of 2.8, previously 5, a power of 5.2, same as previously, speed of 8,000 stable, and a pulsatility index of 3.2. Here the pump of the LVAD. What do you want to do other than call the phone?
Yeah.
Well,
All time to talk.
I have to be in a family meeting.
Just
But I
normal
can't do
patient.
it. I'm on call.
Oh yeah, power. You're right, Amanda. You're right. I meant to switch this. Power should be low. What's that?
There's no way you're looking
Power should.
Do you think
Yeah,
that's
power
true?
usually correlates with flow. You're right. I
Well,
meant
I
to
didn't
switch
know
that.
I was gonna get that wet.
Are you being the
It's
family?
low.
Oh,
Hey, Nevada group. What do y'all think? What do you want to do?
Echocardiogram?
We're gonna go with A.
You want to do an echo?
Yeah.
All right. Anything you might want to do before that? The patient's heart rate's pretty fast.
Probably an EKG as well.
Yeah, let's do it. Let's start with an EKG. and then we'll probably get to an echo, right? I mean, just a normal patient. They're in a tachyarrhythmia, right? You want to get an EKG. That's kind of what I was trying to teach you here.
Hey,
All
Nick,
right, EKG comes back, shows this.
Wait, Nick, we have a question.
Yeah, what's up?
does having an LVAD change your interpretation of an EKG at all?
No, so it really does not. The thing that you're going to be concerned about anyone with arrhythmia, once again, like you're not worried about their LV is offloaded, but an arrhythmia can, really what you're going to be worried about is it's going to decrease your RV filling, right? They're going to be going so quickly that they're not going to allow time for diastole for their RV to fill, which is once again going to lower your preload to your left ventricle, decreasing your flow. But you can interpret an EKG the same.
Yes, it's a wide complex tachycardia.
Yeah, wide complex tachycardia. So what kind of things do you look at to see if it's, what's your differential for that?
So you can have an SVT with an aberrancy.
Yeah.
You can have ventricular tachycardia. You can have somebody with like a single lead pacemaker or something. And then you can have like an accessory pathway.
Perfect. You got really pretty much all of them. What do you think, what kind of things do you look at to tell the difference?
So, I mean, I don't see any of them here, but you could often look for fusions or captures.
Can we mute that?
Oh, sorry.
Can we mute that, please?
We're going to mute one of our sounds because we're
Echoing. This one's
All right, so fusion capture beats, right? I don't see any. What else do you look at?
Sean Dickton explained this to me once, but I don't know if I remember it correctly. He was talking about whether or not the majority of the QRS complex is in the positive direction or in the negative direction. I think he said it was in the lateral leads, but here it seems like
Yeah, so that's called concordance, and you
Yeah.
can look in the precordial leads. Do you think they're all positive or all negative or a mix?
it seems like you have. It seems like it's pretty even up going and down going, but I really can't tell.
Yeah, these are more up right here. And then once you get to V5 and V6, these are most down. So you can't prove VT that way.
Okay. And then some other things you could look for, you could look for P waves anywhere, like hidden, because if you can identify a P wave, then that suggests that there's some sort of supraventricular activity occurring, like kind of noise, if you may, which would probably hint more towards like a ventricular tachycardia.
Yeah, so the thing you're saying is, and I totally agree with you, dissociation of the P's and the QRS and the P waves, right?
Yeah.
So if you have an SVT with aberrancy, it's coming down here, it's going here to the AV node, and then, maybe you have a left bundle branch block, so it's only going to the RV, and it's not going to the LV, right? It's not going down the His-Purkinje system to the LV, and you have myocyte to myocyte conduction along the LV. The P wave will be the same distance from the QRS complex every time with SVT and aberrancy because it uses this whole track, which is going to be different than VTAC, right? VTAC, your ventricles are beating and your atria are beating at the rate of whatever rate that they want. So there's going to be there's going to be something called AV dissociation, which means that the intervals from the QRS to the P waves is not going to be constant. It's hard to say here, honestly. Maybe it's a P. Maybe there's some P wave that may like march through here at the rate of their own bump at their own drum, but I have a hard time really seeing it as well. I think maybe here, and as you see, it's getting a little bit closer every time to the QRS. So that's one thing you can look at, right? Always hard to see P wave, to be honest.
Yeah.
There's three reasons here why this patient might have VT.
Something else I would say, which is probably not what you're getting at, but if the patient had an EKG maybe earlier that day or the day before and had no evidence whatsoever of a bundle branch block, then it's unlikely that this is an SVT with an aberrancy.
So that's a good one too. The only thing you got to remember for that, the one nuance to that is that people can get a rate-related right bundle branch block. So when they have a very, very quick rate, they can get a right bundle branch block because you're not allowing time for repolarization of that right bundle branch. So that's one thing that can be very helpful, though. I agree. So the things I was going to look at here is.
The only thing I would say about the rate-related bundle branch block is
Yep.
usually you have variable cycles, like variable RR intervals.
Yes.
So the refractory period of the right bundle is dependent on like that RR interval. So variable R intervals because that right bundle is dependent on that R interval.
Yeah. And when they're regular like this, you would see it every time though. But yeah, when it's irregular, you might only see it that right bundle every once in a while. All right, the two things you look at is negative in 1, negative in 2 here, positive in AVR. Reason why that proves it's VTAC, so if it's coming from up here to down here, if there's a right bundle branch block, you might have you might have axis deviation, or left bundle branch block, you might get axis deviation. But to get extreme axis deviation, meaning it's negative in 1, negative in 2, positive in AVR, it means that basically your vector of electricity has to be going this way, and if your vector of electricity is going that way, it can really only be coming from the ventricle. So that's why extreme axis deviation proves VTAC. Only other one here is that it's super prolonged. So say here, and then it maybe ends like around here. That's greater than 200 milliseconds, which also proves that most likely be VTAC. Reason why is that you basically have complete myocyte to myocyte conduction of your LV and your RV, which is going to make it much more prolonged. With SVT with aberrancy, it's usually you're going to have normal His-Purkinje system down one way and slowness down the other way. So it's usually going to be less than 200 because one part of your His-Purkinje system is still work and you're getting efficient conduction. The only other thing we're going to look at here, and this kind of goes into the same phenomenon, is that these patients can get something called Brugada criteria. That means the onset of their QRS right here to the nadir of their QRS right here is greater than 100 milliseconds, which is about 120 here. Same general thing. If it's complete myocyte to myocyte conduction, it's just going to take a lot longer. So this was VTAC. All right. The last one is Josephson sign. I don't really know how to explain this, but there's like a little notching here at the end of the QRS. Just something to look for. All right. So it's VTAC. Patient's got VTAC. What do you want to do? Sustained and so right is it? Yeah, sustained beat. Good question. Sustained beat.
What's their mental status? I mean, do we have a baseline Doppler blood pressure?
So the patient's like a little off. They are having they're cold as well, like cool extremities, and they have like a low flow. And they have a low blood pressure, right? This patient's blood pressure is Doppler of 50.
I feel like you're not allowed to shock this patient.
You don't think you're allowed to shock? Who wants to shock them?
Does the VAD not mandate it?
That's what they.
All right, we got one shock.
I want
I'll
to
shock
shock him, but I'm also scared that it's like shorting out the VAD, and
No,
I think that's a bad idea.
I mean, if they're unstable.
We can't figure out between sinus tac and like
Oh.
another.
Exactly, you shock them. So you shock them. These are just patients with a little more information. You shock them. All right. I was just going to go into here, just why, but I feel like I kind of hammered this home, why an arrhythmia causes decreased flow. Basically, arrhythmia causes decreased diastolic filling. You're going way too fast to allow for adequate diastolic filling, which gives you decreased blood flow to the left ventricle, so you actually have decreased LV preload. That's why your flow's down, right?
Hey Nick.
Sorry.
Yo.
We have, this is the Nevada's group. We have a question. So just as far as the ACLS algorithm's concerned, Rabia brought up a good point. Usually we go down that algorithm if it's pulseless VTAC, but in someone with an LVAD who doesn't have a pulse, do you just go down like pulseless VTAC, or?
So if the flow is, that's a great question. If the Doppler flow is, they basically say pulselessness is less than a flow, I think 50.
Oh,
I think it's 50. But this patient's also maintaining their mental status, which is a big thing, right? If they don't maintain their mental status, then you kind of go into the algorithm of a coding patient, versus here you're in the algorithm of a patient who has unstable VT. We're gonna get there. We're gonna get there, Navi.
Other stuff.
All right. Well, sorry. What was your question?
Just do we have to do anything before shocking them? Do we have to do anything like with a pacemaker? Like, do you need to with a finger?
Nope. You just want to shock them.
Okay.
Yeah. Just treat them normal. Treat them normal. All right, so you shock them. Now the patient, like this gets to your question, Rahid, you shock this patient, you're doing the right stuff, but the patient, you can't get the Doppler pulse anymore, and the patient completely is non-responsive, all right? The monitor still looks like you got from VT to VFib. You try to defibrillate the patient, you can use electricity, nothing's going on. Hum is present, always check if the hum is present for any one of these patients. If hum's not present, that means that their LVAD shut off. The patient's unresponsive, and what do you do now?
Since they're truly not responsive and there's nothing going, you would do compressions. You can avoid, at least from what I remember when the CC was saying, if the chest compressions does have a risk of displacing the device, but if the patient is dying, then you have to do compressions.
Perfect. So you kind of hit, I think, all the things that we're worried about, right? So LVAD manufacturers used to put on their LVADs that you shouldn't do chest compressions. There's not a lot of evidence. The only evidence we have is basically 10, I think it was 8 patients. They did it was from the Journal of Resuscitation, 8 patients who actually coded with an LVAD at a pretty large academic hospital. They did a post-analysis to see if any of the patients had displacement of their LVAD, and none of those 8 patients did. And the crazy thing is actually 50% of those patients that they did compressions on lived and actually had a good neurological outcome. So that's kind of the research that we use to say that this patient is unconscious, you can't Doppler a pulse, treat them according to the ACLS algorithm. Amanda.
What would happen if you just displaced the device?
They would, I guess,
Or it's gonna just go out into the
they would, I mean, I guess I would theoretically, they would bleed into their chest and die, but they're already dead.
Okay.
The good news is,
The good news is you didn't really change much. But think about that, 50% of patients that actually had compressions had good neurological outcome and lived, which is crazy. I mean, that's honestly, I feel like a better percentage than patients without LVADs.
Hey, Nick, we have a question.
What's up?
So Rabia brought up a good question. She was asking, like, how is doing compressions better than increasing the speed of the LVAD?
If we're just trying to augment the pumping of the heart, then, you know.
Oh, great. So the reason, yeah, and I should have covered it. Great question. The reason for the compressions is not to get blood from your LV to the system. It's get blood from your RV to the LV. Yeah. So you're right. Your LVAD is completely taking care of your LV. The reason why you're actually doing compressions is from your RV to your LV. So that's why you do them.
Okay, that makes sense.
Yeah, good question.
Basically,
all right.
your RV
I think this is probably our last one for the day. I didn't know it was going to go by so quickly. Who wants to read this?
I'm just kidding.
You got it.
History of pericardial cardiomyopathy, who was heart rate 2, she presents to the hospital with sudden onset hemiplegia for 2 days, as well as some reddish urine. Vitals, T temp is 100.4, heart rate is 80, MAP is 49, respiration is 20, O2 is 96% of room air, white count of 12. LVAD shows a flow of 9 from 5, a power of 9 from 6.5, and a speed of 8,000, which is stable.
So we got hypotension. Do we have high flow or do we have low flow? High flow, right? So we kind of went over this a little bit, so this might be a hard question, but what is your differential for patients that have high flow and they're hypotensive? Yes, yeah, exactly. Decrease anything that you said too. Anything that's going to decrease SVR is going to give you high flow because your cardiac output from the LVAD, your flow from the LVAD is going to increase. And like I said earlier, your flow is kind of based on pressure from your inflow cannula minus pressure from your outflow cannula. And if you have decreased SVR, that pressure difference is going to actually increase, which is going to increase the flow through the LVAD. So good. So there's only one other thing. that does it. And
Nick, is that because your RV becomes hyperdynamic in an attempt to increase your cardiac output?
No, the flow actually goes up because the pressure, the inflow pressure minus your outflow pressure, because your SVR is down, meaning the outflow pressure is going to be down, actually increases. So the flow through the LVAD, since there's less resistance, goes up.
Okay.
All right, there's only one other thing that should be on your differential for high flow, and specifically, what do we see with the power here? What do you guys maybe think's going on? The power, you got a power spike in a patient who's had sudden onset hemiplegia as well as some reddish urine. What did you say, clot? So DIC bleed, so there's a MAHA going on, I think is what you're saying, DIC. So there's something like that going on for sure. The power is up, so power is basically voltage to the device, right? So to keep the device spinning at the same speed, if there's something obstructing in the way, the power is going to go up. And actually the flow is going to go up because the flow is a little bit dependent on power as well. So the patient has a power spike and they just had a clot that was thrown from something. So, what's that? This is a hard one. There's no reason you guys should know this, to be honest. You're saying LVAD thrombosis, right? Yes. Patient has LVAD thrombosis. Perfect. This patient has an LVAD thrombosis. So what happened is they actually got a clot inside of their LVAD, and that clot then actually showered, giving them sudden onset hemiplegia, a stroke. And when the clot's in the LVAD, that's why I put the reddish urine in there, you actually get a macroangiopathic hemolytic anemia, right? So your LDH is going to be up, your haptoglobin is going to be down, basically because it's trying to get through that LVAD, it's trying to get through this clot, and you're actually shearing your red blood cells. Those can be things that you look at to see if the patient has an LVAD thrombosis. The other big thing that you're always going to look at is the power spike. So in patients who have hypotension with high flow, if it's due to a low SVR, they're actually going to maintain their power at a normal level. But when these patients get a obstruction in there, they're going to get a power spike. So that can be kind of what helps you. Of the partial. Yeah, because they got full, the thing would completely stop working.
Okay.
So yeah, you're basically just getting a clot. You're getting a clot right in here. That clot is going to be shearing your RBCs that are moving through the LVAD, causing a macroangiopathic hemolytic anemia. And if that clot thrombose goes into your systemic circulation, I've seen stroke before. I've also seen mesenteric ischemia before that it can cause. The other thing that I want to bring up for these patients is they can be on excess vasodilators. So, anyone that has heart failure, you're going to be trying to decrease their afterload. If you do it too much, from like hydralazine or like an ACE, they can actually have high flow hypotension from vasodilation. That's another thing to think about as well. All right. And then the last part I'll talk about is you actually need to do a ramp study to prove this. And kind of what is a ramp study? So, in a normal functioning LVAD, if you increase the speed, there's a couple things that are going to happen, right? You increase the speed of the inflow right here. If you increase the speed, what do you think is going to happen to the LV diameter?
Shrink. Collapse.
Is that?
Collapse.
It's going to collapse, yeah. So it's going to get smaller, right? You're basically causing LV offloading. And you can see this on an echo. Here it is, normal speed. And then here is when you increase the speed of the LVAD, you get LV collapse. That means the LVAD is working. The next thing you're going to be thinking about is decreased aortic valve opening. And the way I kind of think about this is the only way that your aortic valve here is going to open is from any residual cardiac output from the residual crappy left ventricle, right? If you cause such increased LV offloading by increasing the speed of your LVAD, you're going to have decreased blood in here that the LV is going to pump. So it's not pumping blood out, and you're also going to have a little bit higher pressure here, which is going to decrease the aortic valve opening. So if you increase the speed on an echocardiogram, here is a M mode of it right here. You can see the aortic valve is opening right here. They increase the speed, stops opening. The other one's a little bit more complicated, decreased mitral inflow velocity. Basically, at normal pressure, there's going to be not that much of a pressure difference between your LA and your LV. So any of that blood is going to fill relatively quickly. When you increase LV offloading, that pressure difference is going to go up. It's going to take longer time for your LV to fill from your mitral valve, sorry, from your left atrium. If you do not have these things, you're going to think that there is a thrombosis in there, and increasing the speed is really not doing anything because you have some sort of obstruction. So this is a ramp study. You do a ramp study, and you show basically that the LV diameter barely decreases, the aortic valve remains open, the mitral inflow velocity remains high. What do you guys want to do for this pump? You just proved that there's a pump thrombosis, right? What do you guys think you want to do for this pump thrombosis? So I got heparin, increase the patient antiplatelets. They should be on warfarin at baseline and aspirin. Consider device exchange. Do you want to increase their INR goal while they're in the hospital? Do you want to do an IR-guided mechanical thrombectomy, or do you want to increase the patient's pump speed? Which time we got? We got some A's. Well, you guys agree with A, or does anyone think it's something else? A little nervous about A? She just had a stroke, that's true. All right, well, sorry, and you get a CT scan, there's no bleeding. Good.
Okay.
Yeah, CT scan, no bleeding, great. Forgot to mention that. Andrew, what do you think?
Just because I remember something like this in the CCU where a patient kept having pump thromboses and they tried doing anticoagulation at the platelets, but seems like it was like a hope and a prayer and like a bridge to a device exchange. So that's why I'm not sure why, but it seems to be A.
Okay, all right. And the other group, what do you guys think? Rahid?
I mean, I'm saying A, but I don't think that's the general.
We were also thinking possibly C would help resolve the problem faster.
Okay.
I don't know when that's indicated.
So, can't hear you guys too well, but most people were right, is A. So, and exactly what you were saying, right? You're going to basically take them off their warfarin. You're going to put them on a heparin, right? Because heparin's much quicker reversibility. You may increase their platelets. Sometimes I've seen people go from 81 to 325. I don't know the evidence behind that, but you're right. The thing that you're going to be thinking of is, do I need to exchange this device? If it doesn't work, they need a device exchange, right? There's only one way to remove that. The other ones, increasing their INR goal, you're actually going to be taking them off their warfarin. I don't even know. I just made this one up. I don't even know if that's possible. And increasing their pump speed, I mean, there's an obstruction in there. Theoretically, I guess I could see what you're saying. You increase the pump speed, maybe that would make that obstruction go away. But in practice, that's never really done. All right. That is what I really got for you. These are all just general management questions of heart failure, which you guys had. This is kind of the chart that I like to use. You can either use this one, or this one is probably a little bit nicer. So this is the kind of things that you're going to be thinking about. Just approach every patient with an LVAD, with hypotension, like a normal hypotensive patient, but with more information, right? I think that's really the take-home message here. The other things to think about: pump thrombosis, heparin, increase their antiplatelets, consider device exchange. And hopefully I helped you guys feel a little bit more comfortable with an LVAD. Does anyone have any questions? Yeah, I'll send you the slides, and I recorded most of it. I forgot like the first 5 minutes. So I'll send you I'll put it on YouTube as well.
Thanks, Nick.
Yeah, I could try that maybe. I don't know.
No pressure.
Yeah, no, I'll
YouTube Like,
No, no,
comment,
no,
subscribe.
I meant the
Well, I
slides.
know where to
I meant
look
the
for it.
slides.
I'll put the slides on Canvas.
Okay.
Yeah, I'll put the slides on Canvas.
The slides, yeah.
All right. All good?
Oh, that's the fucking worst.
Like, comment, subscribe.
I walked over.
2 blocks walk.
I'm
So
so, I went, I
Uh,
briefly
question.
shopping.